how can you tell which lens best fits my eye? So this is something that's almost wholly done by a algorithm and a AI inside the machine that measures your eye. The biometer is the name of the machine, and Argos and IOL Master are sort of the top of the line biometers in America or in the world. And what this machine does is it scans the eye, the surface, so the cornea and the power in the cornea. It also scans, the relative position of your native lens in relation to the cornea, and then also how long your eye is from the cornea to the retina. So these factors, along with other factors like the white to white, or the how wide your eye is, and several other factors, they get all these biometric measurements get put into a formula, and we have many formulas. Barrett 2, Kane, Barrett True K, Evo, all sorts of formulas, and some are better than others, or some are more modern than others, and Zeiss AI, and then we look at what intraocular lens power. These formulas, usually they're pretty consistent, but sometimes some of us just favor one formula over the other, and we'll go with that one. But they typically are within a half diopter of each other. There's not too much variation in the formulas. So then we check, we get a number, which is the power of the lens, and then next to it we get the residual refraction, which means if you use this lens, you can theoretically expect this amount of glasses prescription. It's usually like close to zero, right? 0.1 or 0.2. Sometimes even sometimes much less than that. But is that always going to be true? No. The variability here is that when we implant a lens, we don't know where the effective lens position is going to be due to healing. And so as the lens is implanted, we expect it to sit in this position, and therefore with this power it'll generate this theoretical residual refraction. But what we can't control for is, where is this lens ultimately going to sit? Is it going to be this much forward? Is it going to sit a little more back? Is it going to be tilted in a way? That part of healing is outside of any surgeon's control. So you can have some kind of residual refraction afterwards. And the other thing is, some eyes are just prone to having residual refraction. Two examples come to mind. One is the post-refractive eye, so the eye that's had PRK, LASIK, SMILE. These eyes, when they get scanned, our scanners sometimes can't pick up some of the nuances of these surgeries, which reshape the cornea. And so it's going to make its best guess, and you're going to tell it what kind of surgery it had, and it'll have a nomogram. Most of the time, I would say it's right on target. But when it's off target, sometimes it can be significantly off target. But treatment is always the same. You just kind of give it a little time until things have healed in, and then you measure how far off you are. Remove the lens, back calculate a new lens to address all that refractive residual refraction. So the other scenario is very long eyes tend to have long zonules. These are the support structures that hold the lens in place. Now, if your zonules are long, sometimes the lens can have a more variability in its effective lens position. So sometimes it can sit really far forward, but after the healing process, it may migrate, slowly over the course of 3 months back to where it was predicted to be. Or vice versa, it might be on target initially, and then later on it drifts kind of out of target as the healing process takes place. So all of these things are potential issues that can make your vision a little blurrier or suboptimal. But we can always address this. Obviously, we're going to help you through that. And then when the time comes, let's say 3 months afterwards, things have stabilized, we'll do a second surgery to address any residual refraction. So removing the lens, putting in a new lens, and back calculated to, account for all of those variabilities that no surgeon can ever account for. So we'll definitely stand behind you and get you as optimized as possible. But you just have to be aware that 1 in 20, 1 in 40 patients will need a second surgery to achieve the most optimal result. And we'll get you there. Gosh, I forgot the question. Let's see. How can you tell which lens best fits my eye? We've addressed most of this question. The last part is which lens. I would say the best lenses, the best fit for you is going to be based on your expectations and your needs. But most people expect to see near and far all at the same time and in both eyes. So I would say 98% of the time we're using multifocal lenses, and it's very rarely that we use anything other than multifocal lenses. Multifocal lenses, by the way, these days are almost as good as monofocal lenses in contrast sensitivity, light transmission, light allocation, all just very well optimized. And of course, it's going to get better with time, but already extremely good. We sometimes don't use multifocal lenses, and the reason typically is that the eye just isn't healthy enough to tolerate a multifocal lens. There's something different about the eye. It's not completely healthy, and then we choose a non-ringed lens because we think the ringed lens would cause the patient to potentially have more risk of dysphotopsias or unwanted side effects. But those account for maybe less than 5% of our surgeries that we do. And anytime we deviate from a multifocal lens, we have to counsel the patient that multifocal lenses can get you seeing near and far, but because with the rings and non-ringed lenses are typically not going to 100% get you out of glasses, that you will probably be reliant on some glasses, usually for your near reading. So just keep that in mind as well. But thank you.